Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of our today's lesson is acute pneumothorax. What is pneumothorax? Pneumothorax is nothing but the air in the pleural cavity, in between the layers of the pleura, that is parietal and visceral pleural layers. It is associated with some degree of impairment of ventilation and oxygenation. Pneumothorax of three varieties based on the etiology. 1. Traumatic pneumothorax. 2. Iatrogenic pneumothorax. And 3. Tension pneumothorax. Well, traumatic pneumothorax is the most common type of pneumothorax we come across due to the blunt injury or penetrating injury to the chest wall, thereby causing trauma to the pleura and resulting in the sucking in of air that causes the air into the pleural cavity. Iatrogenic pneumothorax. Iatrogenic pneumothorax is another type of traumatic pneumothorax where trauma is induced during the diagnostic or therapeutic procedures on pleural pathology. Well, tension pneumothorax is the type of pneumothorax wherein air gets entry into the pleural cavity without exit. A sort of valvular mechanism exists there in the pathology, thereby resulting in the sucking in of air without exit of the air from the pleural cavity. The pressure gets mounted up in the pleural cavity with the gross shift of mediastinum, the compression of the superior and inferior vena cava, thereby impeding the venous return to heart, which results in the reduced cardiac output and hemodynamic circulatory failure. When not attended and treated properly, it may end up in mortality. These are the three varieties of pneumothorax on the etiological basis. There are other types which are called simple pneumothorax, communicative pneumothorax, and tension pneumothorax. Okay. Simple pneumothorax is the one where there is air in the pleural cavity without mediastinal shift, usually asymptomatic, identified as a accidental incident during the workup of the patient for different diseases. Then you have the communicative hydrocephalus. This is again open type of pneumothorax wherein the injury to the pleura is exposed to exterior. Okay, this is called open type of pneumothorax or communicative pneumothorax. That is, pleural cavity is in communication with the exterior. That means there is an open wound on the chest wall, opening to the pleural cavity, allowing the air entry into the pleural cavity as a phenomenon of sucking in force. Well, the other one is the tension pneumothorax. Okay. So these are the various types of pneumothorax we come across and attend to the management based upon the etiology and degree of clinical manifestations. Look at this picture. This is the ultrasound or no, X-ray chest. Okay. You'll see the here there is pneumothorax on the right side of the chest. There is a pleural white line is there, reflects the, pushed in fold of the pleural membrane. This is the air in the pleural cavity indicating pneumothorax. This is the diagrammatic representation of the chest showing the lung fields, mediastinum, and pleural cavity. Here, this is a normal chest wall. The lungs are normal. Pleural cavity is normal without any air in the pleural cavity. There is mediastinum with the heart in the center, trachea entering into the thoracic cavity. This one is the open pneumothorax. There is injury to the chest wall and pleural cavity is exposed to exterior. And there is sucking in of the air resulting in pneumothorax. There is associated collapse of the lung. There is no mediastinal shift. Okay. This is closed pneumothorax. Okay. Here, there is air in the pleural cavity. There is no mediastinal shift. There is collapse of the lung. Here is the picture showing tension pneumothorax. You see the pressure is mounting up in the pleural cavity. Air is sucked in, but there is no exit for the air. There is collapse of the lung with a gross mediastinal shift to the opposite side. These are the features of tension pneumothorax. Well, pneumothorax is the presence of air in the pleural cavity, which I told you, impairing ventilation or oxygenation or both. It could be traumatic, iatrogenic, or spontaneous. Okay, maybe asymptomatic or maybe severely symptomatic with life-threatening situation. Maybe simple, wherein there is no mediastinal shift, but air is there in the pleural cavity. It is a small pneumothorax, which is symptomatic. Communicating, which the pleural cavity is communicating with the exterior. Another one is the tension pneumothorax. The features we are already talked about. The same way it could be open or closed. It could be symptomatic or asymptomatic. Etiology. Etiology, as I told you, it could be traumatic, it could be iatrogenic. Another one is it could be catamenial, or it could be spontaneous. Right? Traumatic one is the most common type of pneumothorax. Is the result of blunt or penetrating injury to the chest wall. Okay. It could be gunshot injury. It could be stab injury. Or it could be blunt injury when you're driving with a seat belt. You're hit against your steering wheel. And the sudden impact on your chest wall can result in the blunt injury. At the same time, injury to the mediastinum, injury to the pleural cavity. There are so many things can happen in such a situation. Not only the pneumothorax. It can also result in the pneumomediastinum. Right. Trauma is such a dangerous situation that may cause disruption of the pleural membrane. Okay. And its consequences. Spontaneous pneumothorax could be primary in individuals with no associated lung disease. That is spontaneous pneumothorax, primary spontaneous pneumothorax, wherein there is no disease in the lungs. The secondary spontaneous pneumothorax occurs in those with underlying lung disease. Okay. Sometimes there could be significant lung parenchymal disease, for example, subpleural bloods, which may result in spontaneous pneumothorax because of the rupture of the bloods. Okay. Iatrogenic, which again, I told you, the subtype of the traumatic pneumothorax as a result of diagnostic or therapeutic interventions in the form of insertion of a catheter, etc. Simple needle aspiration if the procedure is not done with the taking the precaution for air tightness, it may result in the sucking in of the air into the pleural cavity. Catamenial occurs in the woman during the menstrual period as a result of pleural endometriosis. Then how does the patient present clinically? Clinical presentation varies depending on the etiology and size of the pneumothorax. Well, in some it is asymptomatic, identified during the workup of for some other diseases. It is an incidental finding these individuals. It is usually asymptomatic. Well, chest pain is the most important complaint, the most common type of presentation. It accounts nearly 65 to 85% of the patient coming with pneumothorax due to chest pain. Chest pain is acute and severe. Sometimes it is cutting and stabbing in nature, radiating to the ipsilateral shoulder. Well, it is associated with the shortness of breath. Okay. Well, if it is a primary spontaneous pneumothorax, pain slowly decreases after 24 hours because self-limited gradual resolution of the pneumothorax. It is primary spontaneous pneumothorax because primary spontaneous pneumothorax, as I told you, it occurs in lung without pathology. Okay. Well, if the pneumothorax is less than 2 centimeters, there may not be any clinical symptoms. Many patients with small spontaneous pneumothorax, because they are asymptomatic, they do not seek the medical advice for weeks or for several days. Well, with regard to the tension pneumothorax, the presentation will be with more severe symptoms. Okay. If untreated, the outcome will be fatal. Because, as I told you, because of the one wall mechanism, air will be accumulating in the pleural cavity, resulting in the mediastinal shift and the compression of the inferior vena cava, reduce the venous return to the heart, and decrease the cardiac output, and patient may be going into circulatory failure. Okay, unless treated, the patient will go into peripheral circulatory failure and death. Well, having known the presentation, how do you make the diagnosis and laboratory evaluation? Okay, history is very important. We take the detailed history, whether he is exposed to chest trauma, whether he used to suffer from the milder form of spontaneous pneumothorax, getting relieved of spontaneously. Okay, whether he had undergone some diagnostic procedures earlier. Now he develops a sort of the mild degree of pneumothorax. His history is very important. Okay? Then go for the detailed clinical examination. Examine the vitals, take the vital data, respiratory rate, heart rate, blood pressure. Okay? The patient with tension pneumothorax who presents to the emergency may have severe respiratory distress, tachypnea, tachycardia, okay, and low blood pressure, raised JVP, right? There could be mediastinal shift, the apex is shifted, mediastinal is shifted outside to the opposite side, okay? If there is right side pneumothorax, apex is shifted to next laterally. The tracheal shift to the opposite side, and there is hyperresonant node with absent breath sounds on the side of the lesion. Okay, having recorded the clinical findings, you suspected the pneumothorax, large pneumothorax, attention pneumothorax, etc. Go with the chest X-ray, the rectal posture. Well, most of the occasions, X-ray chest underestimates the size of the pneumothorax. Okay. At the point care, ultrasonography of the chest wall is more sensitive. It helps to estimate the size of the pneumothorax and plan the appropriate treatment. Well, it could be small pneumothorax, that is, presence of a visible rim of less than 2 centimeters between the lung margin and the chest wall. Large pneumothorax, presence of visible rim of more than 2 centimeters between the lung margin and the chest wall. These are the ultrasonographic findings. Okay. So these things will help you to decide the plan of treatment. How do you go about the treatment? Your treatment is guided by etiology and clinical manual presentation. Your goal of treatment is to eliminate the air from the oral cavity. Number 2, help heal the bronchopleural fistula. Okay. Number 3, avoid post-expansion pulmonary edema. Okay. Prevent bacterial infection. Then provide preventive measures to avoid recurrent pneumothorax. So these are the steps of management to reach the goal of the patient with pneumothorax. Well, the treatment plan differs if the patient is asymptomatic or if the patient is symptomatic pneumothorax, stable or unstable vital signs. Okay. If the patient is in tension pneumothorax. If the patient is asymptomatic and you have observed a small primary spontaneous pneumothorax, okay, it is an incidental finding because patient has not come for his pneumothorax. It is identified incidentally during his workup for the other disorders. In this situation, no intervention is required unless there is high risk of recurrence. Even then, pulmonologist is not going to take over the case unless there is referral from the bedside. Okay. As the patient is asymptomatic, when you think there is a risk of progression, and ask him to come with the referral, and the pulmonologist will take care of the patient with specialist care. That's what you have to do for a patient with asymptomatic pneumothorax who was identified having simple pneumothorax incidentally, and there is chance of progression. Okay. Then patient symptomatic pneumothorax with stable vital signs. Proceed with the needless aspiration or insert a small bore thoracostomy catheter with underwater seal. So admit the patient, provide high flow oxygen therapy. Okay. do the interval scheduled check X-ray chest to identify the improvement. This is how we have to do the symptomatic pneumothorax with stable vital signs. And traumatic pneumothorax with stable or unstable vital signs rapidly proceed with the insertion of the thoracostomy tube. Okay, to avoid further progression and the associated complications like circulatory failure, etc. Then, most important part of the management of pneumothorax is pain management. Okay, there is definitely some degree of pain by doing the procedures like thoracostomy and insertion of the tube, and the patient is under the impending catheter. You will have a lot of pain and discomfort about the chest wall at the site of the injury, the site of the wound. So provide local anesthetic for relief of the pain. So you can provide the painless procedures. Following the procedures, give the analgesics, opioid or non-opioid. Antibiotics have to be administered to prevent secondary infection and to prevent complications like impending. Recurrent pneumothorax. When you are encountered a patient with recurrent pneumothorax, okay, you proceed with the fluorodesis, okay, or sclerotherapy. Well, patients with spontaneous pneumothorax, the recurrence risk is found to be around 20 to 60% in next 3 years. When you have come across a patient with spontaneous pneumothorax, he improved very well with the spontaneous resolution, and you plan to discharge. Counsel with him saying that there is a risk of recurrence for a period of 3 years. So he requests scheduled follow-ups in order to avoid complicated pneumothorax. Okay, when unattended may lead to morbidity and mortality. So this is how they want to manage a patient with recurrent pneumothorax. Then a note on complications. So what is the most important complication in pneumothorax? Misdiagnosis is a frequent complication. You missed the diagnosis. Okay. And patient was treated in a different line in discharge. So that is the most common cause of complication. What are the factors? You don't misdiagnose the case. There should be some factors responsible for misdiagnosis of the pneumothorax. What are they? Poor history. You are not taking the perfect history from the patient. Incomplete clinical examination. You missed the, subtle findings. Okay. Diminished air entry, hyperresonant note, etc. You do not have the available chest X-ray right at your center. Then failure to identify pneumothorax in X-ray chest. There is availability of the X-ray, but you are unable to identify the pneumothorax in X-ray chest. So these are some of the factors where you misdiagnose the patient with pneumothorax, and it may lead to the complications. Well, the complications, it may lead to progression to tension pneumothorax, hypoxic respiratory failure. See, undiagnosed, untreated, neglected pneumothorax may lead to progression into tension pneumothorax. You may present in a critical condition to your emergency service. Hypoxic respiratory failure, shock due to circulatory failure, cardiac arrest, again due to hypoxia and acidosis, respiratory arrest, lymphedema secondary to infection, and re-expansion pulmonary edema. So this you have to look into while you are treating the patient. Take care to properly diagnose the patient with pneumothorax. The patient suddenly complains of acute chest pain, severe stabbing nature, following a blunt injury, or whatever it may be the history, it should be taken in detail. The patient comes with chest pain and breathlessness and some degree of hypoxia. Okay? So you should have the high index of suspicion for pneumothorax. Thank you very much, my dear students. We'll meet you again in the next class. Until that time, this is Dr. Masudan Rao. Bye-bye. If you like my video on this particular topic, pneumothorax, please subscribe to my channel. And we'll keep continuing the talks on different interested topics. Give me the feedback. Give me the list of topics you want in the videos. I'm ready to prepare the videos for you and present them effectively. Thank you very much once again for viewing my video. We'll meet you again in the next class. Until that time, bye-bye.